So, dear colleagues, ladies and gentlemen, a heartfelt welcome to all of you. Thank you for coming into this session, and I also thank Novartis for sponsoring of the session. We will be two of us, and this is a Meet the Expert session. So it will not be only presentation from our side, but discussion afterwards. So we would like to have a lot of time for discussion to answer your questions. My task is to give you a presentation on the disease and the burden of the disease. And Nicolino Ruperto, well known from everybody, I think, will then give us a look into the future. So these are some disclosures, as you may read, and some housekeeping remarks. So this is our agenda. I will now directly go to point 2, the unmet needs in juvenile psoriatic arthritis and enthesitis-related arthritis, the physicians and the patient perspective. So there are some learning objectives, as you can see here. We will look at the disease, explore the disease, and clinical features, activities, and then we will discuss the patient perspective. And finally, we will come to the evidence for IL-17 inhibition in the patient group of enthesitis-related arthritis and psoriatic arthritis in childhood. So my presentation has the title Understanding the Unmet Needs in Juvenile Psoriatic Arthritis and Enthesitis-related Arthritis, the Physicians and Patients Perspective. I have some personal disclosures, and I would like to introduce to you a typical case. A 14-year-old boy, previously healthy, sportive, no infections, no thick bites, and then he develops complaints for a long time, limping, sport activity interrupted, painful first toe, pain on the Achilles tendons, chronic lower back pain, but no waking up at night, morning stiffness so far, and the family history gives a grandfather with ankylosing spondylitis. So the diagnosis is, I think, very clear to every one of us. So there's the diagnostics. So clinically, you found swollen joints, you found tenderness on the heel, which indicates enthesitis. You have reduced Schober's sign, so a reduced mobility of the spine. You have a tenderness by pressing the iliopsoas joint. You have the Mendel sign positive. You can check for pain scores, and the child has assessment questionnaire. Diagnostics reads HLA-B27 as in his grandfather's, and the MRI indicates active sarcoiditis. So ERA, this is the subtype of GIA the patient suffers from, is about 10 to 20% of all cases. It is more boys than girls. This is the older boys, and a negative B27 positive in about 2/3 of the patients. The distribution of the arthritis involved is more the lower extremity. There is enthesitis you have to look for, and if there is uveitis, this is usually a symptomatic uveitis with red eye, as seen in my patient. It was a different patient. So back pain and sacroiliitis are possible. It's not obligatory, but it's possible, and usually there's a family history. There is an EILA classification for this disease, so it's classification criteria, not diagnostic criteria. This is if you have arthritis and enthesitis, and if there is only arthritis or enthesitis, you can check for a list of criteria, and if there are at least 2 are present, you can classify the patient according to this criteria. However, if there is psoriasis in the patient or in the first relative, then this is an exclusion, as well as the presence of rheumatoid factors. So this is the initiation of a second case, which is different. So this boy presents with limping for several weeks. He has swelling of finger joints. He needs help for dressing. No previous infection, no thick bites, and the father has psoriasis. So by investigation, you can see there's a swelling of the right first interphalangeal joint, the left proximal interphalangeal joint number 2, and a swollen and warm right knee with normal range of motion. The patient has no psoriasis and no nail abnormalities. Ultrasound of the knee joints revealed effusion and synovial thickening, and ANAs were positive. So the diagnosis to be given in this child is ANA-positive GIA, oligoarthritis, since only 3 joints are affected, but the patient is not fulfilling the EILA criteria for juvenile psoriatic arthritis. Treatment with NSAIDs is started. 3 months later, the patient presented with dactylitis, still no skin psoriasis, no nail abnormalities, and with dactylitis, now the diagnosis of juvenile psoriatic arthritis is possible, and treatment with methotrexate was started. You can see the swollen finger, the picture above, and this paradoppler signs and the tendon and the exudation around the tendon. So treatment failed. The patient developed psoriasis upon treatment. The patient has nail psoriasis, and by ultrasound an erosion was detected. So second treatment was started. In this case, a biologic etanercept was given to the patient. So this brings us to psoriatic arthritis. This is more rare. It's only 6 to 8% of cases according to our calculation in Germany. This is the association of psoriasis and arthritis in children and adolescents. Arthritis affects about 20% of those children who have psoriasis, but only in 10% psoriasis and arthritis occurs simultaneously. In about half of the cases, psoriasis follows the arthritis, so the diagnosis is a little obscure. It's definite if there is arthritis and psoriasis, and it's indefinite if psoriasis is lacking. You need classification criteria. There have been 3 developed so far, the Vancouver criteria, which were the first, following by the EILA classification criteria, and adults usually use the CASPA criteria, which are so far not validated for children. So these are the classification criteria for juvenile psoriatic arthritis according to EILA. There is arthritis and psoriasis, and if psoriasis is lacking, you can diagnose the patient as PsA if there is arthritis and dactylitis, nail abnormalities, or psoriasis in a first degree relative. However, there are some exclusion criteria to be followed. The problem is that this classification criteria misses a lot of patients. So also the case I presented to you was not able to be classified by the criteria. By the Vancouver criteria may be an option. However, statistically, about half of the patients fulfilling the Vancouver criteria were missed with the EILA criteria. Of note, juvenile psoriatic arthritis has 2 phenotypes. There is an early phenotype which resembles the course of oligoarthritis and polyarthritis, as the case I demonstrated to you, or at school age, the course may be similar to ERA patients. So you can see here, taken from a publication, that the early onset have a very young peak age, that there were more females, that they were ANA-positive, but the later onset patients were more males or females, and the same, they have B27, enthesitis, sacroiliitis, and if patients develop uveitis, patients with early onset develop chronic uveitis, as you know from oligoarthritis and polyarthritis, and the ERA patients develop more the acute anterior uveitis, which is here. So what is the outcome of the patients? And I'd like to introduce to you the inception cohort we have built up in Germany. It starts collecting patients with new onset of the disease in 2010, and we aimed to follow the patient for 10 years, and now we were able to analyze the data. And if you like to know where St. Augustine is, you may see this as a town in the hills with skiing and so, but St. Augustine is near of Cologne at the River Rhine. So this is where I'm working. So in the ICON cohort, after 12 months of the disease, the patients of several GIA categories were analyzed according to the disease activity. And as you can see here, all of the patients showed inactive disease after 1 year of routine care, and about 40% patients with systemic GIA did perform the best, with 2/3 in inactive disease, others by 50%, but the lowest performers were the juvenile psoriatic arthritis and enthesitis-related arthritis patients. So this gives a glance on what drugs are approved until 2022. So in ERA patients, you have the sulfasalazine Methotrexate is approved in polyarticular courses. You have 2 TNF inhibitors and, as a new player, the secukinumab. While in juvenile psoriatic arthritis, we have approval for methotrexate in polyarticular courses. We have the etanercept only in children older than 12 years. And we have secukinumab, IL-17, and ustekinumab, L23-12 inhibitor. And very new since last year, there's also a JAK inhibitor approved for this drug. So I like to conclude the first part of our presentation that we have treatment guidelines who first recommend to use methotrexate or sulfasalazine in these patient groups. We have etanercept as an approved biologic for juvenile psoriatic arthritis following a failure of methotrexate, or etanercept and adalimumab in ERA patients. However, in clinical practice, much less than 50% of patients are treated successfully. Therefore, I conclude there is a need for better treatment, earlier treatment initiation, and additional options. I thank you for listening, and we will now directly come to the second speaker. This is Professor Niccolò Ruperto from Gaslini Institute, Genoa in Italy. Please, Nico.
So thank you, Gerd, for the nice introduction, and to Novartis for organizing this workshop with all of you. So today I'm going to speak about a post-hoc analysis of a trial which has already been presented in past occasion here at Press, and not only at Press, and which has already been published, as some of you might already know. So the novelty about this trial is the fact that it is the first drug which has been specifically dedicated to 2 categories of JAA, enthesitis-related arthritis and juvenile psoriatic arthritis, which we all know belongs to the vast group of spondyloarthropathies. So this is just to remember to all of you what in the trial was done. This was a classic withdrawal design in which children with classified as ERA or JPsA, which have not responded to non-steroidal or at least one disease-modifying anti-rheumatic drugs, have been treated in an open fashion up to 3 months with secukinumab, a specific dedicated anti-IL-17 drug. Then the responder, according to the classic JIA-ACR criteria, have been randomized either to continue with the drug or to be switched to placebo, in order to look the rate of flare and the time to flare, which is related to the use of this drug. And today what I'm going to do is to present this post-hoc analysis, which give you an idea about the efficacy and safety profile up to 2 years of treatment initiation. So this is the patient disposition. A total of 86 patients have been enrolled. Of these, 75 meet the criteria for response and have been therefore randomized either to continue with the drug or to be switched to placebo. And with these 2 simple boxes, you immediately appreciate the rate of flare, because we had 21 flares in the group of patients switched to placebo, as opposed to only 10 in the group of patients to continue with secukinumab. And here, the patient who flare or finish the second part of the trial enter the long-term extension, which is still ongoing. Now let's have a look briefly to the baseline characteristic. As you could expect, these patients were more male for the known epidemiological reason, but probably what is most important for you is to appreciate the fact that these were patients with a high level of disease activity, as shown by the JIA-ACR component. When we look more precisely to the specific characteristic of the 2 populations, you see that for the enthesitis-related arthritis, these patients have somewhat more enthesitis, as expected, while the psoriatic arthritis have more dactylitis and also somewhere a more higher level of involvement from the articular point of view. So looking directly to the results, here you could appreciate the JIA-ACR response, And let's have a look at what is, I think, important from a clinical point of view. If you concentrate on this yellow line, you could see that after 3 months of treatment, up to 36% of the total population reach already a status of inactive disease, so quite a strong outcome, and about a 70% a level of improvement equal to the JAA CR70. When we look at the population in this post-hoc analysis divided into ERA and PsA, you could essentially appreciate the fact that the response was similar and overlapping in enthesitis-related arthritis and in psoriatic arthritis, with again more than 1/3 of the patient reaching a status of inactive disease as expressed by the yellow line. But probably the figure which best depicts the influence of secukinumab on disease activity is represented by the JDAS, the Juvenile Arthritis Disease Activity Score, in its 27th version. Here you could see that for enthesitis-related arthritis, all patients started in a status of high disease activity, the pink part of the graph. In the initial 3 months, they already move rapidly to a status of moderate disease activity, and the disease activity continued to improve for those who continue on secukinumab in the second part, with most of the patients reaching a status of minimal disease activity. And the same trend, I will not spend now too much time, so to save time for the discussion, could be clearly observed also for the patient with juvenile psoriatic arthritis. This is again to remind the main trial, which show the time to disease flare in the two populations combined. Here I would like to point it out just one message which I think is clinically important, which is reported over here, that the time to disease flare, the median time to disease flare with secukinumab in the patient who switched to placebo was equal to 453 days, meaning that the effect of the drug persists and control the disease of the patient even much further after the half-life of the drug that is given every 4 weeks. Here you could see the same figure for enthesitis-related arthritis, but since this is a post-hoc analysis, this is not statistically significant, and indeed for ERA, we could not calculate the median time to flare, while for psoriatic arthritis, you could see that the same figure is equal to 271 days, again, showing how the effect of the drug persists despite the switch to placebo. But let's have a look more precisely on what might count in the everyday clinical practice. And this graph shows the complete resolution of something that is specifically related to enthesitis-related arthritis and psoriatic arthritis, such as the resolution of enthesitis and dactylitis, that in both populations occur in more than 60% of the patient already after within 3 months of treatment. These are the components of a new index specifically dedicated to juvenile spondyloarthritis, by which you could appreciate that inflammatory back pain and morning stiffness completely resolve within 3 months in more than 75% of the population, and in more than 50, there was a complete resolution of the related sign. While this one is more specific for psoriatic arthritis, by which you could appreciate that after 3 months of treatment, 50% has a complete disappearance of psoriasis, while if you combine these two parts of the graph, 91% of the patients had at least an almost clear evaluation of the psoriatic lesion of these patients. Let's now move to the safety. This is the overall safety with the number of patients who got at least an adverse events. You could see that when we compare secukinumab and placebo, we could not see too much difference, besides the fact some small sign related to the number of patients who discontinue to adverse events. But probably from a clinical point of view, it's more interesting to look at this one, which report the patient, the adverse events which occur in at least 5% of the population. And here you could appreciate that, as expected, the majority of adverse events were related to upper respiratory tract infection, with some patients having nausea, diarrhea, and headache. So, in conclusion, secukinumab in these two JAA category, ERA and JPsA, demonstrated a longer time to flare and more flare when compared to placebo, but the effect on the signs and symptoms persist up to 2 years of treatment, with also an improvement on measures which are specific for these two disease categories. And the safety profile, no new signal in pediatrics, and the safety profile is essentially in line with what we know from our adult colleague. So let me thank all centers who participate in this study, which make the study possible, belonging to the Printo and PRCS network, and of course, the sponsor. And thank you very much. Yes.
So thank you, Nico. So we are now open for your questions. You are coming here to meet us as expert. Please go to the microphone. Wonderful.
Hello, Natasha from Slovenia. Do we have any data on the efficacy of anti-IL-17 in patients who fail anti-TNF in enthesitis-related arthritis? Speaking from the clinical perspective, because we have patients like this.
So far as I know, in patients have been in part on biologics before. So there was 1/3. So there was no hint.
No. In the trial, patient could not have been treated with a biologic agent. So at the moment, we cannot respond to this information. So because to have the population, let's say, cleaner, it was decided that failure to another biologic agent was not allowed.
What about from clinical experience? Do you have some?
This is a difficult question because of the Czech Republic, let's say, regulation, we are not allowed to express our personal opinion on the treatment of the population which is not a part of the label. So it's a very long response to say that I cannot answer. Sorry.
I thought you would like to have our clinical experience with the drug in this approved situation.
You mean in the patient who did not respond to anti-TNF. This is why yes, I know. But this is what we have been unfortunately requested to do.
So far as I understood, the approval is not limited to biologic naive patients.
No.
It's also possible to treat those patients. And as you know, we have this experience already. The drug is used and is also used in my unit. And we also have success in patients who have failure to TNF inhibitor. So these are usually the first patients you will treat with a new drug. This brings me to the question to you. What do you think about the position of the drug in the context? Are there already recommendations for this in Italy?
No, in Italy there are not yet a recommendation. I think the position of this drug, as I briefly mentioned during my introduction, is the fact that it is the first drug dedicated to a JAA specific category. Now, as you know, to facilitate, let's say, the possibility for the physician to prescribe biologic agents, we introduced many years ago this concept of polyarticular course JAA, by which all children with more than 5 active joints could be treated with the drug which have been approved so far. In this case, I think we are moving to the next generation of trials, where on the contrary, the molecule we are studying are specifically directed towards something that is typical of that disease category. So, as just because of this, I think we could all understand that this drug might play an important role for the treatment of these children.
So any further questions? Frank, please.
Are you aware of any adult data in dermatologic psoriasis and treating that either with baricitinib or tofacitinib versus secukinumab? There is no head-to-head study as far as I'm aware, but are there any data indicating that one treatment principle might be superior in psoriatic arthritis or psoriasis, since the approval for treating psoriasis has predated the approval for psoriatic arthritis?
So as you know, in childhood, I can answer only for childhood, there are no comparative studies. So one with the other, usually the trials are done placebo-controlled. But if you, let's say, make a kind of a comparison in the open label phases of the drugs, you can then conclude from these that efficacy in psoriasis with IL-17 inhibition is much higher than those with TNF inhibition. This also led to a modification of the German guidelines for treatment of juvenile psoriasis.
Okay, nothing more to add on this point. Other questions?
But do you think the differential indication, so this is what he asked for, if you have a patient, when would you decide to treat the patient with TNF inhibitor, let's say a patient with psoriatic arthritis or an IL-17 inhibitor?
Difficult question, but for the prior reason, I think that once a physician decides that is the time to switch to a so-called more powerful drug like a biologic, I think that this drug should have its own place as potentially first choice in the mind of the clinician. And I would like to have also your opinion on that.
So while I've made the experience a couple of months ago that I have a patient admitted by my colleagues, and by my visit the patient was presented and he has polyarthritis, enthesitis, and trunk was full of psoriasis. So this was the decision, what to do now. So the patient failed the first DMARD, with methotrexate, and then we discussed with the patient, it was a 15-year-old boy, that there were several options. I asked him, what is hurting you more? It's the psoriasis, not the joint pain.
And this highlights one important aspect, that now the discussion with the family plays a central role in the decision. It's not only a physician decision, but it's really a discussion with the family, or if not with the patient himself, if of adequate age. And we are in a lucky situation of offering different possibilities, and so this greatly facilitates our work.
So there would be time for one more question. 1 minute, one question, please.
Thank you for a great talk. A question regarding the patient that have rash compared to those that didn't have psoriatic rash. Did you find any difference in terms of outcome? So that they were diagnosed with juvenile psoriatic arthritis, but they didn't have rash.
The number of patients who had a psoriatic lesion clearly indicated that not all the patients had psoriasis to start with. So the effect on the psoriatic lesion was quite clear, because most of them had a clear resolution. If you are asking if the general outcome of the patient with or without a skin lesion was different, I cannot answer, because this has not been yet looked at.
Yeah, that was the question. Because you include patients that were diagnosed with juvenile psoriatic arthritis by criteria, even if they didn't have rash.
We all know that the criteria have some pros and cons. For example, here I have to say that the company was quite willing to consider the problem related to the classification criteria, because children with lower age in order to discard those which were just ANA positive, and so maybe a different one, have been in a way considered differently. Let's say.
Yeah. Right.
And so this was some vision for the future.
Thanks.
Okay.
So no more questions. Thank you for your presentation, Nico.
One more question, please.
One more question there. Oh,
Yeah.
sorry.
Do you have any additional data about immunogenicity, about anti-drug antibodies?
There were essentially no detection of antibodies to the drug, in line with what we know from the adult literature. Because sometimes I think your question underlined the fact that we have observed in the past that children do have are more prone to the development of antibodies. In this case, it does not appear to be the case. So with other drugs, we observe this effect, but not here. So perfectly in line with what we already know from the adult.
Okay, sorry that I overlooked you, but can happen, my excuse. So again, thank you for coming, thank you for listening, and thank you for the discussion, and enjoy the Congress.
Okay.